You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for January 25th, 2019. This week, I'm talking aspirin, alcohol and atrial fibrillation, troponin, women in cardiology. First up is aspirin and primary prevention. In 2018, 3 big trials studied aspirin for primary prevention. This was ARRIVE in patients with high cardiovascular risk, ASCEND in patients with diabetes, and Aspirin in older individuals. And you know the results. There were no mortality differences, except in Aspirin, aspirin looked worse than placebo. There were tiny reductions in non-fatal cardiovascular events and definite increases in bleeding. And the short story for 2018, no net benefit for aspirin in 3 big RCTs. This year, 2019, 2 British authors added these trials to 8 previous RCTs, and they came up with a 13-trial meta-analysis with 164,000 participants. This, my friends, is a definitive analysis. JAMA published the study. The median age was 62, median cardiovascular risk 9.2%, and the results. For cardiovascular events, there were 57 per 10,000 in the aspirin group and 61 per 10,000 in the placebo arm. That's a relative risk reduction of 11% and an absolute risk reduction of only 0.4% and an NNT of 265. And bleeding, it was 23 per 10,000 for aspirin, 16 per 10,000 for placebo. Relative risk increase 43%. Absolute risk reduction 0.7%, and a number needed to harm of 210. There was no difference in cardiovascular mortality, overall mortality, and cancer. There was very low heterogeneity. And the take-home is, why would you take a drug that has tiny reductions of non-fatal events but a larger risk of bleeding and no difference in death rate? And the answer is you would not. Now the caveats. Aspirin has known net benefits for patients with established heart disease and during MI and after PCI procedures, and we shouldn't confuse the 2 types of patients, primary versus secondary prevention. And as pointed out in a well-written editorial by Dr. Michael Gaziano, in the future, there may be genetic markers or there may be artificial intelligence means to help refine risk prediction and maybe identify some groups of primary prevention patients that have higher risk that may benefit from aspirin. And my final comment on this topic is that you don't need guidelines for this kind of stuff. Any practitioner can easily translate this data in this meta-analysis in about a minute, and then patients and doctors can decide on this for themselves. Second topic is alcohol and atrial fibrillation. A really nifty study from the lab of John Kalman and Peter Kissler in Melbourne shed mechanistic light on the Afib and alcohol story. And first, some background. Everyone knows about holiday heart. This is where atrial fibrillation can associate with binge drinking, and that's because alcohol has definite acute electrophysiologic effects on the atria. What's less well known is the alcohol effect on atrial fibrillation is unlike the French paradox, meaning with alcohol, even 1 drink per day increases the risk of atrial fibrillation, and then the risk subsequently goes up in sort of linear fashion with more drinks per day equals more risk of atrial fibrillation. So the Australian investigators asked why this could be, and they set out to determine the impact of different degrees of alcohol intake on atrial remodeling. And they used high-density electroanatomical mapping, which sounds tricky, but really electroanatomical mapping is made easy with current AF mapping ablation tools. They enrolled 75 patients, and they studied the left atrial electrical properties in these 3 groups who came for AF ablation. And the groups were non-drinkers, mild drinkers, and moderate drinkers. And they found that moderate drinkers compared with non-drinkers had lower left atrial voltage, slower left atrial conduction velocity, and more complex atrial electrograms. And for the non-EP listeners, these properties set the physiologic stage for atrial fibrillation. They increased AF vulnerability. Now, of course, this study is observational and it uses self-reported alcohol intake. but the fact that alcohol can associate with significant atrial electrical disease provides plausibility to the clinical observational studies. I'm going to add these findings to my discussion with patients. Indeed, I think mechanistic studies such as this help frame discussions with patients, meaning you can say alcohol associates with atrial fibrillation because potentially it causes changes in the atrium. And then if the next step is reducing alcohol intake, maybe will make the atrium more electrically healthy, and that's how it reduces Afib incidence. Third topic today, high sensitivity troponin. High sensitivity troponin is coming to the U.S., and I am frightened. In JACC, authors of the PROMISE study, PROMISE was CCTA versus functional stress testing in stable patients with chest pain, published a cohort or sub-study of patients who had blood drawn before any event or angiography in that study. The original PROMISE study had 10,000 patients, and that found no difference in the primary composite outcome, death, MI, or unstable angina, in the CCTA versus functional stress testing arm. And this sub-study included 4,000 patients who had blood draws. The authors aimed to evaluate the prognostic value of a super high sensitivity single molecule high sensitivity troponin test, which, importantly, is not available on the market yet. Now, the first finding that struck me was that 99% of patients had measurable troponin. And the authors broke the concentrations of high sensitivity troponin into quartiles from low to high levels. Again, notably, all of these levels were in the normal range. They found that higher concentrations of high sensitivity troponin associated with a higher chance of a cardiovascular event. And in multivariate analysis, troponin concentration independently predicted death, MI, unstable angina, particularly in the short follow-up. So the authors concluded and spent many words in the discussion saying that these findings suggest a role for measuring high sensitivity troponin as part of the overall strategy for evaluation of stable chest symptoms. Now, here's why I'm frightened. These are prominent researchers writing in a leading journal, and there are millions of people who present with chest pain. And thus, when high sensitivity troponin comes, this paper could have great influence. Now, the number of patients in PROMISE who had events in this sub-study was 78. Imagine changing the approach to chest pain in millions of patients based on a sub-study with only 78 events. Now, to be fair, I want to be totally fair, the authors called for more study in their discussion. The second issue with these findings are the Kaplan-Meier curves showing higher rates of events in the higher quartile of troponin concentrations has a massively truncated y-axis, and it goes from 0 to 3%. So the absolute difference of events between low and high troponin levels still within the normal range is less than 2%. So my pro tip here is you guys always look at the y-axis of Kaplan-Meier curves. Third point, the authors discussed the difficulty in using different levels of high sensitivity troponin that may toggle right on one of the cutoffs, say 2.5 versus 2.8. Now the former, 2.5, is in the third quartile, the latter in the highest quartile. So how does a clinician sort that out when trying to take care of patients? The other problem here is that patients in the higher quartile of high sensitivity troponin also had more standard risk factors. Thus, I found the key sentence in the second paragraph of this study, and here it is, quote, addition of high sensitivity troponin resulted in an increase in bias-corrected C statistic from 0.65 to 0.68. Now remember, with C statistics, 0.5 is a coin toss. The point there is how much, in addition to typical risk factors, does the high sensitivity troponin add? Now, perhaps I should be more optimistic. Maybe we could say by the time high sensitivity troponin assays come to fruition, doctors will have become better at using this test. Maybe the fact that this generation of clinicians, the younger generation, they never learned medicine in the era when any enzyme elevation equaled MI. And so maybe they'll be better at using these enzyme tests. But based on my point of view here in the real world, imaging and procedures power the cardiology engines, and people still disbelieve the many trials that prove that interventions don't improve outcomes in patients with stable coronary disease. So therefore, I can't help but see a strong correlation with increasing troponin assay sensitivity and overdiagnosis and overtreatment. The more sensitive we make troponin assays, the more we will make people into patients. Last topic is women in cardiology. Now, results of an online survey of fellows in training regarding perspectives on choosing a cardiology specialty deserve attention. First of all, before I tell you about the survey, I want to say and note how much the field of cardiology has changed. Dramatic changes. When I started, there were 3 choices: general, interventional, and EP. And now there are at least 6 different groups within cardiology. So the survey had about 600 fellows respond, and the authors sought to determine the factors that influence fellows to pursue a career in interventional cardiology and how these factors differ by sex. First, men were 4 times more likely to choose interventional cardiology. But the things in this survey that caught my attention were the positively and negatively influencing factors. Men were more likely to be influenced by positive attributes of IC, interventional cardiology, and women more likely to be influenced by negative attributes, which were revealing, like low job flexibility, physically demanding nature of the job, radiation during childbearing, old boys culture, lack of female role models, and sex discrimination. Now here, I highlight this study in this podcast because I'm optimistic. My point of view is colored by my position here in this group in Louisville Cardiology, and in my group, almost half the partners are female, and 2 of our 6 interventionalists are women. And in my first group, which I practiced for half my career here in Louisville, there was a female managing partner, and it was quite a successful group. I think the culture of cardiology as a boys' club is changing for the better. And the key, I believe, is increasing the numbers of women in mentorship roles. For instance, just yesterday, I was asked why I chose EP as a field, and the answer was easy. It's because of inspiring mentors. Now, the other thing that women will influence is a move to a more sane scheduling process. This includes embracing of shift-based scheduling. And this needs to happen. It's insane for clinicians to be fixing STEMIs all night and then work the next day in a grueling clinic. How is this a good idea? It's stupid. And just because we did it in the past is absolutely not a reason to continue it. So as the old generations move on and the new generations move in, I think that these changes are more likely to happen. Now, one comment to my younger listeners, and this is men and women alike. I have immense respect for interventional cardiologists. Fixing STEMIs is one of the most clearly beneficial things that are done in all of medicine. It's beautiful. But you all need to know that this is a super hard job. And while pulling people from the jaws of death looks cool and sexy during training, and it's cool, after a decade or 2, your view may change. At age 45 or age 50, things sometimes look different than they do at age 28. And I know this might sound cliched and it might even be trite, but the way doctors take care of themselves is bad. We need to do a better job taking care of ourselves. And this isn't selfish. It's mastery of the obvious. More women in the field, in my opinion, hopefully will promote this. Finally, my colleague, Dr. Melissa Walton-Shirley, has a great column on sexism, ageism, very relevant to this topic, and I'd highly recommend it. As usual, Dr. Walton-Shirley is spot on. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. And remember, if you like this podcast, please subscribe. Consider giving us a 5-star rating or writing a comment so other people can find it. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.